Skeletal system imaging. Types of cells: osteoblasts, osteoclasts, osteocytes. Osteoblasts are the formed during growth and repair. Blast means germ or bud, immature cell or tissue that later develops into specialized cell or form. The skeletal system is always in a constant state of repair. Osteoclasts are removal of bone. They are the mature osteoblasts that no longer produce new bone tissue. Function is to support daily cellular activities of bone tissue. The osteocytes are mature osteoblasts incorporated into the mineralized matrix and communicates with other cells. Which cell is most abundant? It would be the osteocytes. Why do a bone scale? We do bone scans for skeletal lesions, staging of skeletal disease, evaluate metabolic activity of skeletal disease, no role in congenital bone disease. X-rays are best to demonstrate this. We are the best for acquired bone diseases. X-ray versus bone scans. 30 to 50% of bone must be decalcified before tumors or infections can be detected with X-rays. Bone scans only require 1 to 2% decalcification to yield abnormal bone scan. Patient prep. Patients need to be well hydrated and then have them force fluids after the injection and post-scan. The patient setup. Void and remove all attenuators. Clothes are okay. Patient needs to be comfortable. Tell the patient to hold still. Tie tourniquet. May do a tail-on detector if necessary. Radiopharmaceuticals. Diphosphonates. Localizes in hydroxyapatite crystals by absorption and ion exchange with bone matrix, reflecting osteoblastic activity and skeletal vascularity. Tells how active the bone is. There's two radiopharmaceuticals that can be used. There's the MDP and the HDP. HDP is also known as HMDP. A critical organ. A critical organ would be something like the bladder because that is where the radiopharmaceutical is being let out of the body. So what isotope is used here? It's obviously MDP because that's the only one we really talked about, or HDP. You can't tell the difference. What's wrong with this image? What's wrong with their arms? Well, obviously there's an attenuator there, so what they did is you see how it's all uptake in the soft tissue that was infiltrated, and it just went into the soft tissue more than it went into the bone. Technical parameters. Diverging collimator allows to see larger field. It is used on standard field of view crystal multiple passes, and it will give a zipper effect. LEHR is better collimator when worried about image quality. A gap or a leap is better when worried about sensitivity. You'll get more counts with a gap or a leap. Leap provides better sensitivity for flow studies. These are the parallel holes. These are diverging. This is converging, and this is a pinhole. Obviously, parallel just runs straight up and down. Diverging runs outward, so you can get a larger field of view. Converging kind of pulls in for a smaller field of view, and then a pinhole is more of a direct, specific point. So what's wrong here? What's wrong here? This is the zipper effect that they were talking about earlier. And they used the wrong photo peak. That's why they didn't acquire any bones. What happened here? You see all these extra fingers. That was a patient that was moving while they were on the table. What type of scan is this? The diagnosis can be infection, stress fracture, avascular necrosis, vascularity of lesion, differentiate cellulitis from osteomyelitis, and post-hip replacement surgery. Phase 1. Why do you include both region of interest and contralateral field of view? You include both of them so you can compare the difference between the two. Bolus injection and record flow images 2 to 4 seconds for 60 seconds. So bolus injection and record the flow images 2 to 4 seconds for 60 seconds. You get perfusion to the area, which is flow. Lasts a minute or two. This is just showing the flow, but it's not normal to be injecting into the contralateral. That's not normal. This is just showing you where it went for the flow, and then it stayed afterwards. So if it was during the flow, the immediate, and then the 3-hour image, or 2-hour image, I guess is what they use, 2 hours on that. That means that it's osteomyelitis because it's infected into the bone. If it was just in these two phases, then it would be cellulitis. Phase 2, aka blood pools or immediate statics. It's the same position as the flow, and you go for 500,000 counts. Phase 3, it's a routine bone scan. Patient returns in how many hours post-dose? 2 hours, and then the max is up to 5 hours. It shows bone metabolism, just how bones are reacting. Phase 4 is rare. People rarely do this. A physician may want a 5 to 6 or a 24-hour spot image of the region of interest. They may be evaluating the vascularity, the static 10-minute picture. The diagnosis is breast cancer or prostate cancer. The procedure would be same as the bone, except compare the scapula versus the rib. Alright, so scapula versus the ribs. This one, what's wrong here, you see the patient moved a lot also. SPECT. Use SPECT when superimposition of the bones. You may increase the dose. You need more counts and more gamma, or it could increase the time. Positioning is critical. Needs symmetrical and aligned to get a clear picture. Advantages of SPECT are better contrast resolution, ability to separate underlying and overlaying structures, but note that spatial resolution is not necessarily improved when doing SPECT. These are just the slices that we see with the transverse, the sagittal, and the coronal. This is a MIP, which stands for multi-image projection. Here we have a bone fracture for SPECT CT. You see right in here is where the bone fracture is. You can see because it's all lit up. This is with the fusion image. And the X-ray, you see it right there as well. Factors affecting bone images: hydration, renal failure, and the amounts of scatter. Scatter increases when. So for the renal failure, the renal function increases the body background with poor target to non-target ratio. Amount of scatter. Scatter increases when the patient's size is larger. The organ detector is the detector is far away from the patient, and both images will be degraded. Factors affecting bone images: poor tag of radiopharmaceutical. That'll give you free tech, and if you have free tech in the poor tagging, then you'll see the salivary glands light up, and you'll see the mucosa glands light up, and the gastrointestinal glands will light up, or organs. If you introduce air into the kit, it'll cause oxidation and weakens the effect of the radiopharmaceutical. Free tech goes where? Like I said earlier, the salivary, or also thyroid and gastric mucosa. Thin layer chromatography. Check to see if the tag is bad. That's the strip where you see where the tech is. So what happened here? Okay, you can see that was poor tagging because you have the gastric mucosa, the thyroid, and the salivary glands all lit up. It's all free tech. The age of this patient is obviously a child or infant. You could tell by the hot spots on their joints, and those are the growing joints, and that they said in class is probably a diaper. Normals. Contralateral regions for symmetry want to look the same, mirror images. Normal symmetry may be found in the skull, shoulders, and rib ends. Normal increased activity in the spine, long bone ends, scapula tips, and joints. How do you move scapula tips out of the way? You can raise your arms up over your head, or the patient's arms up over their head while scanning, or crossing them over in the front, but moving them up over their head is preferred. Right here you have the scapula tips, so if they stay there and you have the patient image with their arms up, then obviously the hot spots are probably from like a breast cancer or something along those lines. But if these move when you move the patient's arms up, then they're parts of the scapula tips. So this one, what do we see wrong? There is a ton wrong with this picture. Still not very clear what that's supposed to look like, but it's not enough time between the injection and the scan, or it could be dehydration. It could also be contamination all over the person. What happened here? Okay, so you see how their arm is extremely hot, and it did kind of, some of it went, but you see a lot of that soft tissue also. That's because they injected into an artery instead of a vein. Okay, increased uptake in the bone of the arm and concentration of activity blood flow to those bones. Radiopharmaceutical accumulation, increased uptake. Primary bone tumor, METs, osteomyelitis, trauma, which bone damage and or repair, degenerative changes, osteoid, osteoma, Paget's disease, and arthritis. Photopenic areas with decreased uptake. Instrumentation artifact, attenuation artifact, which is pacemaker or barium as well, radiation therapy, chemotherapy, an infarct, early osteomyelitis, assist, age, impaired or no blood flow, a bone infarct, complete destruction, AVN, which is avascular necrosis, abscess, multiple myeloma, cancer of the plasma cells in the bone marrow. Benign bone tumors, intense uptake on delays. Fibrous dysplasia, a bone disease that destroys and replaces normal bone with fibrous bone tissue. May be single or multiple bone lesions. Osteoblastoma is an uncommon bone tissue forming primary neoplasm of the bone. Usually occurs in patients under 30, more prevalent in males, pain that is not relieved with NSAID, non-steroidal anti-inflammatory drugs. Osteoma is a rare primary tumor, also occurs in patients under the age of 30. The pain that is relieved with non-steroidal anti-inflammatory drugs. So we're assuming that the osteoma creates inflammation, which causes pain, and that is why the NSAID helps in the relieving of the pain. Osteoblastoma, you can see a lot going on down here, especially in the knee. And by the size of that patient, it looks like it was probably a child of some sort. Osteoid osteoma, you can see here in the hands when they turn them sideways as well. Benign bone tumors, moderate uptake. Chondroblastoma. Chondro means cartilage. Rare, slow-growing tumor. In peds, most common epiphyseal tumor. Causes muscle deterioration, decreased movement in joints, and pain. Endochondroma is cartilage tumor that appears on the inside of the bone, often occur in the small bones in the hand and feet. most common tumor of the hand, usually solitary movement. Benign bone tumors, faint uptake. A bone island, which is also known as anostosis, benign growth of bone or cartilage inside a bone. Non-ossifying fibroma is a non-aggressive tumor, consists mainly of fibrous tissue, usually occurs in the thigh bone or shin bone, resolves by itself. Osteoma, a new piece of bone usually growing on another piece of bone, usually the skull. Surgery is only necessary if causing symptoms. It can be anywhere. Osteoma can be anywhere. Benign bone tumors. No uptake or a cold spot would be bone cyst with fracture. A variable hemangioma. Abnormal buildup of the blood vessels on the skin or in an organ, usually hard to notice on the bone scan. Multiple hereditary exostosis. Bony bumps. Formation of new bone on the surface of a bone. Usually occurs on long bones, pelvis, and shoulder bones. Here you can see the exostosis where this bone is where it shouldn't be. A malignant bone tumor. Intense uptake. Ewing's sarcoma, also known as osteogenic sarcoma or osteosarcoma, is a malignant bone tumor. Usually occurs in teenagers. Moderate adamantinoma. Adamantinoma is a rare, slow-growing bone cancer, usually found in the shin bone, tibia, or jawbone, mandible, but may be in the forearm, hands, or feet as well. Makes up less than 1% of all bone cancers. Occurs in males between the ages of 10 and 30. Treatment is wide resection or amputation. Chemo or radiation therapy does not work. The book says that the adamantinoma is benign, but it is a very, very low-grade malignant. Ewing sarcoma. You have these 3 or 4 spots that they're showing you. There's the one in the skull, and then you have the ones in the ribs, and then you have the one up near the right femur. I believe that's right. Yeah. Then you have the ones down by the shins as well. Malignant versus benign. Scan for vascularity and to determine number or localization of sites. If blood pool images show little or no increased uptake, then usually what would that mean? If blood pool image shows intense uptake, then malignant. So if the blood pool image shows an intense uptake, then the tumor would be malignant. There are some exceptions, but that is the standard. Bone scans allow us to detect lesions in difficult areas not clearly seen on radiographs. What is ideal to do in this case? Spect. When in doubt, spect it out. Malignant is hotter than benign. Sensitivity is high, but the specificity is low. Repeat that again. Malignant tumors are hotter than benign tumors. The sensitivity is high, but the specificity is low. Metabolic disorders usually affects entire skeleton. Osteomalacia and Paget's disease. Osteomalacia is the softening of the bone, whereas osteoporosis is the loss of bone. Osteomalacia, which is also known as adult rickets disease. It is a vitamin D deficiency caused by inadequate sun or poor diet. It's the malabsorption syndrome, defective vitamin D production because of liver disease, or chronic use of anticonvulsant drugs. You'll have increased uptake. Paget's disease. Increased uptake in the bone scan, enlargement of the skull, pelvis, and or long bone. The bones grow irregularly. Seen in the skull, femur, vertebra, or half of the pelvis. Here, this is Paget's disease. See, the skull is lit up really, really, really high. Oh, this is Paget's. And here you can tell they had a hip replacement. I think this is actually Paget's disease. I don't know if that has anything to do with the hip replacement, but that's what we were told in class. Metastatic disease. Cancer spread from the primary place to bone, usually spread to proximal bone. An example would be breast cancer may spread to the ribs. 80% with known neoplasms and bone pain usually have METs on scan. 30 to 50% of patients with METs have no pain. Bone scan is 95% sensitive in detecting METs. Lesions can be detected 6 months earlier than X-ray because they show function. Widespread METs. A person looks like a Dalmatian. This person has it everywhere. It's not good looking. Soft tissue uptake. When notice soft tissue uptake, what would you do first? Make sure there's no contamination is the first thing to do. Soft tissue neoplasms may calcify and demonstrate activity. Malignant pleural effusion or malignant ascites. Recent infarction in the brain, heart, or spleen. Why would you see breast activity on a female? You may see breast activity from menstruation. A soft tissue tumor, you can see right here, this big old lump right there, that is the tumor. See more than just bones. Renal failure can be concluded with what? A delayed radiopharmaceutical clearance. Unilateral increased activity in only one kidney may be due to what? An obstruction. Increased activity in the spleen may indicate some kind of infection or even sickle cell disease. What is sickle cell? It's a recessive genetic disease and you experience bone pain. You may also see dental work, recent dental work. Also the medallion effect, which is a distal portion of the manubrium photopanic. This is your medallion effect, your manubrium. In young children, why would the medical doctor order a bone scan? See fractures or tons of reasons. Abuse. Alright, so fractures and traumas. If positive within 24 hours of injury suggests what? 80% positive for fracture from 24 to 72 hours. 95% positive for fracture is after 72 hours. Want to wait 3 days to confirm fracture. Bone bruises or hairline fractures don't show on x-rays. Rib fractures versus METs. A rib fracture appears linear in a straight line going down. That might be a test question. This rib fracture appears linear in a straight line going down. So what happened here? Oh, their ribs over here. All of their ribs are fractured. Trauma, stress fractures are difficult to see on an x-ray and not seen for 7 to 10 days. Shin splints, medial tibia stress syndrome. Normal activity on the blood pool and flow, and linear increased activity. What happened here? These are shin splints. Let's see them. Osteomyelitis versus cellulitis. Osteomyelitis is infection of the bone and cellulitis is infection of the skin. Need to distinguish because of the treatment plan. Cellulitis is short-term antibiotics. Osteomyelitis requires surgery. The radiopharmaceutical used is diphosphonates. Gallium-67, indium-111, or technetium-99 leukocytes. It's tagged red blood cells. Osteomyelitis for cellulitis. Early signs of osteomyelitis are not demonstrated as clearly on the radiographs as a 3-phase bone scan is. Osteomyelitis has increased uptake on all 3 phases, which cellulitis has increased uptake on 1 and 2 phases. What is the ideal modality to differentiate osteomyelitis from cellulitis? MRI. The downfalls: very expensive scan, insurance may not cover it, and limited due to magnet. Here we see the 3 phases: phase 1, phase 2, phase 3. Since this is still hot, that is osteomyelitis. Septic arthritis, increased activity in all phases of a 3-phase bone scan. How can you tell the difference between the septic arthritis and osteomyelitis? Osteo is a focal increase in the joint, whereas septic is diffused in green bone. Septic typically means systemically, so you'll see it throughout more than one spot. Right here you see septic arthritis. It's not focal, it's in multiple spots. Discitis is swelling, inflammation, and irritation of intervertebral disc space. It's just inflammation of the discs. It occurs in children under the age of 10 years old. The cause is unknown, and increased activity in 2 lumbar vertebrae. Right here you see the discitis, you see it inflamed right there. This is how it will appear on our scans. Hypertrophic pulmonary osteoarthropathy. Pathy means condition, so bone joint condition. Usually seen in patients with lung cancer. Parallel lines of activity around the knees, ankle, and wrists. Once patient is treated for this disease, activity may decrease. Hypertrophic pulmonary osteoarthropathy. You see here, 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 here. You see the lining right on the outside of the joints, along the lung bones actually. You see the lining on the outside. Avascular necrosis, AVN. Avascularity of the head of the metaphysic of long bones, usually due to trauma, but may be secondary to fracture, sickle cell, alcoholism, or steroid use. Initially, there is an absence of a tracer uptake in the ROI. Later, there is a healing phase of the bone repair with activation of osteoblasts and increased uptake. Lose blood supply, infarct, or lack of blood. You see right here, there's nothing in here. Nothing in here. They're not getting anything. Spontaneous osteonecrosis of the knee. Usually patient will get onset of acute knee pain. It's most common in females. It's demonstrated as increased activity in the medial or lateral femoral condyle. Radiation therapy. Important factors and what do you ask the patient? Cumulative amount of radiation, fractionation of doses, length of time after therapy. So when they're getting radiation therapy, we need to know how long it has been since they had the fractionated dose of therapy. Within 1 month of a patient receiving fractionated doses will cause a decrease in the localized vascular patency in area of treatment. Returns to normal in roughly 6 months, and then uptake may reduce again. So at the 6-month mark is when we will start doing our scans again. We can do it after a month, but the best imaging possible is going to be after 6 months. RSD, which is reflex sympathetic dystrophy. Pain and tenderness, swelling, and instability in the affected limb. Vasodilation or vasoconstriction. May be caused from trauma, myocardial infarction, or neurologic abnormality. On X-rays, it shows as a patchy area around the joints. On the 3-phase bone scan, increased flow in immediates followed by asymmetric uptake around all joints, usually in the hands or foot on delays. Right here, we see in these images, it's not asymmetric, obviously. There's a big difference between the two. The patient diagnosis is RSD. So what is wrong with the image? All right, well, you see some right down here. It's not asymmetrical. Probably that. Let me go for the RSD again. On the three-phase bone scan shows increased flow in immediates, followed by asymmetric uptake around all joints, usually in the hand or the foot. I see some in there, but it's more focal than it is all joints. Bone mineral measurements. Indications. Primary osteoporosis, hyperparathyroidism, osteomalacia, multiple myeloma, diffuse METs, glucocorticoid therapy. Decreased bone mass, cause of large number of fractures in elderly patients. The highest risk of fracture is in the vertebral and femoral neck. How to measure bone mineral content. There's DEXA and DPA. DEXA stands for dual X-ray absorptiometry. DPA is dual photon absorptiometry. The DPA uses a radionuclide. Both use a highly collimated beam of photons or X-rays which pass through the body and hit a detector on the opposite side. Intensity of the beam exiting the body is indirectly proportional to the density of the area being examined, compared to a standard phantom of known density to then determine the bone mineral density of the patient. DEXA scan time is about 2 to 5 minutes as compared to the 20 to 40 minutes scan for the DPA. With DEXA, there's no need to constantly purchase radiopharmaceuticals or calibration. DEXA also has better imaging. False positives with bone mineral content are falsely elevated. Aortic calcifications, scoliosis, compression fractures, calcium or barium GI tract, and acids, usually compared to X-rays to avoid improper readings. Controversy. Wide variety of measurements within a wide population. Site of evaluation debatable since bone mineral loss is not uniformly degraded throughout the body. Osteoporosis. Is this a valid reason to do a bone scan? No. Osteoporosis is the loss of bone tissue, so for that you would do a bone density scan. Bone marrow imaging. Indication. Define bone marrow distribution. The radiopharmaceutical use is sulfur colloid because it localizes in the bone marrow. Imaging. In adults where the bone marrow is prevalent is skulls, ribs, sternum, vertebral bodies, pelvis, and proximal humerus and femur. In pediatrics, it extends to the extremities. Liver and spleen may need to be shielded. Why? To get the actual counts from the marrow. The best modality to use for bone marrow imaging is actually MRI. That is the end.